lecture series, and this is going to be retinal vascular diseases chapter 13 part 2. And in this part we are going to discuss about the signs of the diabetic retinopathy. So signs are basically those which we see with uh, our eyes. So signs can be microaneurysms. So microaneurysms are the localized pouching, mainly circular or of the capillary wall, that may form either by the focal dilatation of the capillary wall where the pericytes are absent, or by the fusion of two arms of the capillary loop. So basically microaneurysm occur whenever that capillaries have a pericyte. So when there is a loss of this pericytes, there is a dilatation of the capillaries, uh, and or if there is a capillary loop, there is a fusion of the loops. Most develop in inner capillary plexus ganglion cell layer, frequently adjacent to the areas of the capillary non-perfusion. So they occur in the ganglion cell layer. Loss of pericyte may also lead to endothelial cell proliferation with the formation of the cellular microaneurysm. So whenever there is a loss of pericyte, there is like a endothelial cell proliferation as well, which can lead to cellular microaneurysm. Microaneurysm may leak plasma constitute into the retina as a result of breakdown into the blood retinal barrier or may thrombose. They tend to be the earliest sign of diabetic retinopathy. Signs are the tiny red dots, often initially temporal to the fovea, may be indistinguishable clinically from the dot hemorrhage. So, what can we see? There are tiny red dots in the eye, and they are usually temporal to the fovea, which may be indistinguishable clinically from the dot hemorrhages. Fluorescein angiography FA also allows differentiation between the dot hemorrhages and the non-thrombosed microaneurysm. Early frames show tiny hyperfluorescent dot, typically more numerous than visible clinically. Late frame shows diffuse hyperfluorescence due to leakage. So whenever there is a fluorescent angiography we do, so this will differentiate the dot hemorrhages from the non-thrombosed microaneurysms, and it will show as a tiny hyperfluorescent dot, and it will be more numerous than visible clinically. And late frames will show diffuse hyperfluorescence due to leakage. So this is a microaneurysm histopathology. So you can see that there is a two arms of the capillary loops which can fuse together to form the microaneurysm. So this is a circular microaneurysm. So A is showing the two arms of the capillary loop that may fuse to become a microaneurysm, flat preparation of the India and ink injected retina. B is showing an area of capillary non-perfusion adjacent microaneurysm, flat preparation of the India ink injected retina. So this is an area of capillary non-perfusion, and this is an area of microaneurysms. So C is showing a xenophilic dark pink degenerated pericytes, and D is showing microaneurysm with endothelial cell proliferation. So this is known as a cellular microaneurysms. So this is an early changes. A is showing microaneurysm, so you can see the microaneurysms and dot hemorrhages at the posterior pole. FA show the scattered hyperfluorescent spot in the posterior fundus. So you can see the tiny hyperfluorescent spots. Next is the retinal hemorrhages. So retinal hemorrhages can be retinal nerve fiber layer hemorrhage, arises from the larger superficial precapillary arterioles and assume their characteristic shape. So when the precapillary arterioles are being affected, so this can lead to hemorrhage, which is flame shaped hemorrhages, because of the architecture of the retinal nerve fiber layer. Intraretinal hemorrhages arise from the venous end of the capillaries and are located in the compact middle layer of the retina with the resultant red dot plot configuration. So the most common is the red dot plot configuration, that is basically when the venous end of the capillaries are being affected, and it is located in the middle layers of retina. Deep darker round hemorrhages present hemorrhagic retinal infarct and are located within the middle retinal layer. The extent of involvement is a significant markers of the likelihood of the progression to PDR. So this is an hemorrhage in 13.4 is showing retinal hemorrhage. A is showing histology showing blood lying diffusely in the retinal nerve fiber layer and ganglion cell layer, and as globules in the outer layers. So this is a outer layer and it is lying as a globule. And B is showing us a retinal nerve fiber layer hemorrhage, flame shaped hemorrhage. So this is a flame shaped hemorrhages. And C is showing us a dot plot hemorrhages, and D is showing us a deep dark hemorrhages. Next is an exudates. So exudates are caused by the chronic localized edema, retinal edema. So whenever there is a retinal edema, there can be exudate formation. They develop at the junction of the normal and edematous retina that are composed of a lipoprotein. So they are basically lipid filled material. So they are lipoprotein and lipid filled macrophages located mainly in within the outer plexiform layer. So its location is in the outer plexiform layer. Hyperlipidemia may increase the likelihood of the exudate formation. So signs are that it is a waxy yellow lesion with relatively distinct margin arranged in clumps or ring at the posterior pole, often surrounding a leaky microaneurysm. So most of the time it is surrounding a leaky microaneurysm, and these are arranged in clumps or in the round shape pattern. With the time, the number and size tend to increase and the fovea may be involved. When leakage ceases, exudate absorbs spontaneously over the period of months, either into healthy surrounding capillaries or by phagocytosis. Chronic leakage leads to enlargement and deposition of the crystalline cholesterol. FA will commonly show hypofluorescence only with a large, dense exudate. So in whenever you do fluorescent angiography, it will show that there will be a large hypofluorescence if there is a large exudate. Although background choroidal fluorescence is marked, retinal capillary fluorescence is generally preserved overlying the lesion. So this is an exudate. So A is showing histology showing irregular eosinophilic deposit mainly in the outer plexiform layer. So this is an eosinophilic deposit in the mainly outer plexiform layer. B is showing small exudates and microaneurysms. So these are the exudates. And C is showing more extensive exudates forming a circinate pattern. So this is forming a circinate pattern. D is showing exudate involving the fovea, including the central crystalline cholesterol deposition. So next is a diabetic macular edema. Diabetic maculopathy or foveal edema, exudate or ischemia. So is the most common cause of a visual impairment in a diabetic patient, particularly type 2 diabetes. So when there is a diabetic macular edema, there is going to be the visual deficit. Diffuse retinal edema is caused by extensive capillary leakage and localized edema by the focal leakage from the microaneurysms and dilated capillary segments. So if there is a diffuse edema, it will cause the it will occur from the extensive capillary leakage, and if there is a localized edema, it will cause by the focal leakage from the microaneurysm and dilated capillary segments. The fluid is initially located between the outer plexiform and the inner nuclear layer. Later, it may also involve the inner plexiform layer and nerve fiber layer until it eventually involve the entire thickness of the retina becomes edematous. So first, it will involve basically outer plexiform layer and the inner nuclear layer, and then it involved inner plexiform layer and nerve fiber layer, and then the whole thickness is being involved. With central accumulation of the fluid, the fovea assume a cystoid appearance, cystoid macular edema that is readily detectable on optical coherence tomography. So if there is a if the fovea is being involved, they causes the cyst like appearance, and it is known as a cystoid macular edema. Focal maculopathy. So it can be focal maculopathy and diffuse maculopathy. So focal can be due to the focal leakage or the microaneurysm. It is basically well circumscribed retinal thickening associated with complete or incomplete ring of exudates. So there will be the retinal thickening with associated with exudate. FA shows late focal hypofluorescence due to leakage, usually with a good macular profusion. So there will be a very small or focal hyperfluorescence which will be due to leakage. Diffuse maculopathy, diffuse retinal thickening, which may be associated with cystoid changes. They are typically also scattered microaneurysm and small hemorrhages. Landmarks may be obscured by edema, which may render localization of the fovea impossible. FA show mid to late phase diffuse hyperfluorescence and demonstrate CMO if present. So this is a cystoid macular edema. It is a AOCD showing retinal thickening and cystoid spaces. So you can see cystoid spaces here. FA show a leaky microaneurysm and a central diffuse hyperfluorescence. So there is a very diffuse hyperfluorescence, and it is showing a diffuse macular edema with the flowered petal configuration. So this is showing focal diabetic maculopathy. So you can see that there is a retinal thickening which is associated with the basically circinate pattern of hard exudate. So FA late phase show focal area of hyperfluorescence due to leakage corresponding to the center of the exudate ring. So this is a area of the retinal thickening associated with exudates. And 13.8 is showing a diffuse diabetic maculopathy. A is showing dot plot hemorrhage, diffuse retinal thickening, which can be difficult to see clinically. B is showing late phase, showing a extensive hyperfluorescence at the posterior fold due to leakage in the same patient. So you can see that there is a diffuse leakage of the macula. Now there can be the ischemic maculopathy. Ischemic maculopathy means that there is going to be hypofluorescence and there will be the capillary dropout. The signs are variable and the macula may look relatively normal despite reduced facial acuity. In other cases, pre-proliferative diabetic retinopathy may be present. FA shows the capillary non-perfusion at the fovea and enlarged foveal avascular zone, and frequently other areas of capillary non-perfusion at the posterior pole and the periphery. So you can see that this is an ischemic diabetic maculopathy. So A is showing lots of dot plot hemorrhages. You can see the cotton wool spots as well. And B is showing, FA is showing, so this is a hypofluorescence area due to capillary non-perfusion at macula, and elsewhere it is showing that there is an ischemic maculopathy. So next is basically clinical significant macular edema. So clinical significant macular edema is basically we give the uh, type of macular edema depending on how it is visible clinically. So CSMO or is detected on clinical in examination as defined by ETDRS. So you can see this is the basically ETDRS. ETDRS is basically showing that there is a retinal thickening if it is almost 5, basically retinal thickening which is about 500 micrometer, and any part of which is within a 500 micrometer of the fovea. So you know this is a center of the fovea. So this is a retinal thickening. So this is a you can see this is a fovea and this is the center of the macula usually. And what is if there is a retinal thickening that is present within a 500 micrometer distance in the center of the macula, it is known as a clinical significant macular edema. Second is that if there is an retinal thickening with exudates, and any part of the exudates which lies within a 500 micrometer of the center of the fovea, it is known as a clinical significant uh, macular edema. And if there is a macular edema which is greater than 1 disc diameter, and any part of which is within a 1 disc diameter of the center of the macula, it is known as a clinical significant macular edema. So let's see, there is a 3 criteria. There is a retinal thickening within a 500 micrometer of the center of the macula, it is known as a clinical significant macular edema. Exudates within a 500 micrometer of the center of the macula, if associated with retinal thickening, the thickening itself may be outside the 500 micrometer. Retinal thickening 1 disc diameter or larger, any part of which is within the 1 disc diameter of the center of the macula. Next is a cotton wool spot. So cotton wool spots are basically when there is an ischemic changes, and it is basically the accumulation of the neuronal debris. So cotton wool spots are composed of the accumulation of the neuronal debris within a nerve fiber layer. They result from the ischemic disruption of the nerve axon, the swollen of which are known as a cystoid body, seen on light microscopy as a globular structures in the nerve fiber layer. A cotton wool spot heal Debris is removed by autolysis and phagocytosis. Small, fluffy, whitish superficial lesion that obscure underlying blood vessels. So there will be the fluffiest lesion that uh, will be obscuring the underlying blood vessels. They are clinically evident only in the post equatorial retina, where the nerve fiber layer is of sufficient thickness to render them visible. Fluorescent angiography show focal hypofluorescence due to local ischemia and the blockage of the background choroidal fluorescence. So there can be hypofluorescence that will be occurring in a case of a cotton wool spot because there is a local ischemia and there is a blockage of a background choroidal fluorescence. So you can see this is a cotton wool spot. So histology is showing the cystoid bodies in the retinal nerve fiber layer, and B is showing clinical appearance. So this is a fluffy whitish material, and C is showing the pre-proliferative retinopathy showing IRMA. So you can see arrow here. So next is the venous changes in the case of a diabetic retinopathy. Venous anomalies can be seen in ischemia, consist of a generalized dilatation and tortuosity. So whenever there is a venous changes, there is some kind of ischemia that is being present. So there can be generalized dilatation and tortuosity. There can be looping. There can be beading, which is basically focal narrowing and dilatation, focal narrowing and sausage-like segmentations. The extent of the retinal area exhibiting venous changes correlate with the likelihood of developing proliferative disease. So the more the venous changes, the more there is going to be the likelihood of the proliferative disease. So this is a venous changes. A is showing looping, looping. B is showing us a beading, focal narrowing and dilatation, and C is showing us severe segmentation. So segmentation is when there is, you can see like there is a segment of the nerves, veins. Next is the intraretinal microvascular abnormalities, which is known as IRMA. Intraretinal microvascular abnormalities are the arteriolar venular shunts that runs from the retinal arterioles to venules bypassing the capillary bed and are therefore seen as an adjacent to areas of a marked capillary non-perfusion. So when the capillary areas are being non-perfused, so what happens is there is a development of shunt between the retinal arteries and retinal venules. So this shunt formation is known as IRMA, but they will not leak on fluorescent angiography. They may feel like they are new vessels, but they are basically traveling from arteriole to venule, and they will be fine irregular. So the signs, there will be fine irregular red intraretinal lines that run from the arteriole to venules without crossing the major blood vessels. So one thing, they will not cross the major blood vessels. They will be fine irregular and red intraretinal lines. FA may show focal hyperfluorescence associated with adjacent areas of capillary closure but without leakage. So there will be no leakage, but there will be focal hyperfluorescence. So we can see figure 13.13. So this is an IRMA, intraretinal microvascular abnormality. A is showing histopathology, showing arteriovenular shunt. So this is an arteriovenular shunt and a few microaneurysms with poorly perfused capillary bed, flat preparation of India in injected retina. B is showing clinical appearance. So you can see that there is a arteriole, so there, and to venule, so there is a type of a shunt formation. Next is the arterial changes. So there can be arterial changes as well. There can be subtle retinal arteriolar dilatation, which may be an early marker of ischemic dysfunction. So the arteries can also get dilated when significant ischemia is present. Include peripheral narrowing, so there will be the narrowing of the arteries. There can be silver wiring, there can be obliteration. So most of the time these are due to hypertension, but in a severe cases it can occur, similar to the late appearance following a branch retinal artery occlusion. So next is a proliferative retinopathy. So proliferative retinopathy is when there are new vessel formation. It has been estimated that over 1/4 of the retina must be non-perfused before the PTR develops. So 1/4 of the retina must be non-perfused. Although the pre-retinal new vessels may arise anywhere in the retina, they are most commonly seen at the posterior wall. Fibrous tissue, initially fine, gradually develops as vessels increases in size. So there can be new vessels at disc, New vessels elsewhere, new vessels on iris. So new vessels on disc describe a new vascularization on or within a one disc diameter of the optic nerve head. So we have discussed it earlier. So this is an optic nerve head. If there is a new vessels on the optic nerve or around the one disc diameter of the optic nerve, it is known as NVDs. NVEs describe the neovascularization further from the disc. It may be associated with fibrosis if long standing. There can be new vessels on iris, known as rubeosis irides, carrying a likelihood of progression to neovascular glaucoma. Fluorescent angiography highlights neovascularization during the early phases of angiogram and show irregular expanding hyperfluorescence during the later stage due to intense leakage. So in the fluorescence angiography, it will show intense leakage of the dye from the neovascular tissue. FA can be used to confirm the presence of new vessels if the clinical diagnosis is in doubt, and also delineate areas of a ischemic retina that might be selectively targeted for laser treatment. So fluorescent angiography can be done to diagnose this, and also for the targeting of the laser treatment as well. So this is a disc new vessel, so you can see the new vessels at the disc, and B is showing us a severe with the cotton wool spots. So there is a new vessels along the cotton wool spot. C is showing the there is new vessels, uh, disc leakage, leaking disc vessels with extensive capillary dropout. So there is a capillary dropout and a small focus of a leaking capillary vessels elsewhere. Now this is a new vessels elsewhere. A is showing mild new vessels, B is showing severe, and C is showing associated with fibrosis. So these are new vessels which is associated with fibrosis. This is severe new vessels, and this is a new vessels here, and this is a new vessels in the iris, rubeosis iridis. So that's it for the diabetic retinopathy part 2. See you in the next lecture.